Well, good evening, friends. It is Hump Day Happy Hour with Dentist in the Know. I am Chad Duplantis, and I'm here with two of my great friends tonight. Unfortunately, Dr. Jeff Horowitz is not with us. He is up in the Pacific Northwest, supposedly learning. I believe he might be licking a gum wall right now and maybe heading over to a Starbucks for a coffee. He is in the Seattle area. You never know what happens. And apparently what happens in Seattle stays in Seattle because Jeff might just be sleepless in Seattle. But anyhow, folks, we are Dentist in the Know. It is your backstage pass to all the trends, politics, and current issues in dentistry. It is live. It is over a cocktail. My Dentist in the Know Yeti tonight. Dentist in the Know is unbiased, unfiltered, unpolitical, your real live way of figuring out what's going on in dentistry. And we are all dentists, and we hopefully are all in the know. But I'm here tonight with two people, one that you will recognize, Dr. Jennifer Bell, and the other that you might recognize because he's a regular on the show. I mean, he's like Pat Sajak's daughter on Wheel of Fortune. This is Dr. Ryan Walsh, the donk, the dentist out of the know.
Is that a thing? Was Pat Sajak's daughter commonly on there?
Oh, she's on there. Oh, seriously, JB.
Yeah.
I think once you crest 45, you become a regular wheel watcher. You join the club. You hope your name gets called out at the end of the show. But Pat Sajak's daughter's on there like every day. Every day.
I sure appreciate you correlating me to Maggie Sajak. That rocks.
There you go. I couldn't even remember her name. The 39-year-old in the group remembers her name. It is Maggie Sajak. So anyhow, yeah.
Hey, Ryan, I think you might be close to qualifying for your own Yeti.
Oh, sweet.
Right? Look at that thing.
Oh, man. That's
Jim.
I have this butte right here.
Yeah.
You can see right through her.
Oh, you're back with the Pizza Hut.
Oh, yeah. You got to dance with the girl that brought you.
That's awesome stuff. So anyhow, folks, we're here tonight, and Jeff's not here. Jeff's always got everything lined up in front of him. And honestly, I really didn't know that I might be the only dentist in the know on the show tonight. So my intro was horrible. I apologize. I wasn't very
in Seattle.
I did throw out Sleepless in Seattle. That was pretty good. Jeff might be licking a gum wall. Who knows what Jeff's doing right now? Jeff's actually probably still on a plane, isn't he?
Yeah, I think he is.
Yeah. So anyhow, before we get too caught up in what we're going to talk about tonight, JB, tell us a little bit about your week.
It's been an adventure. As you know, I went to Minneapolis, which I've never been to before, in the great state of Michigan. No, I'm kidding. Minnesota. I'm kidding, guys. Kidding.
Yeah.
Everything's in Michigan now, apparently, as far as I'm concerned. And so I was really honored. I got my MAGD. It was a really nice ceremony. Thank you. I appreciate that. And then, the shit show that started on Friday with the whole airline thing, like the crowd strike thing, the guy who tripped over a cable at Microsoft, however it all went down, did drastically impact my return trip. And myself, with many millions of other Americans, found ourselves enjoying a lot of the atmosphere of your local airport. And so to all our fellow travelers out there still stuck in airports or trying to figure out ways to get home, Godspeed. It's pretty much a disaster. There were no rental cars. Luckily, I think still hotel rooms if you could get out. The problem is that, like, when your flight's not canceled, but it's just in perpetual delay, you don't want to leave because you're like, well, they could call. Like, we could be out of here any minute. I did that. So I was supposed to board a plane at 10. My first flight was at 7. That was canceled. Supposed to rebooked on a new flight at 10:30. Was supposed to board. We finally get on the plane at 4:30. I'm getting out of here, people. Peace out, Minneapolis. Gots to go. Only to sit on that plane for another 2 hours. and watch. As soon as I got on, the co-pilot timed out and he said, hit my requirement. He walks off, and for the next 2 hours, they tried to find us another pilot. I've never seen so much sadness as when because I could see the pilot sitting in the cockpit, the captain, staring out the window, watching for a pilot to come by as if his best friend or a puppy might just walk by the window at any moment. And he's just staring and waiting for hours on end, only for him to say, guys, there's no one coming. So we just got our stuff and walked right back into the airport and started.
And this was still in St. Paul or Minneapolis?
Minneapolis, 7 hours later. So we all went back and guys, as much as it sucked, and it did suck, like I felt so bad for the kids on that plane and the parents who were trying to manage the children, because they had already been at the airport for almost 8 hours and probably longer than that. And anyway, long story short, we finally got rebooked and got to get home, but it was not fun. I had one friend rent a car for $1,300 to get home. It was kind of, we were waiting for the Lord of the Flies. Like there was going to be a stick with a pig's head on it at any moment. People were going to be taking other people's stuff. Like it was getting real. Anyway, I was trying to go to Seattle today for COIS Symposium to be with my friend Jeff. And again, the debacles of the airlines kind of continue, and one delay after another. So I'm here with you, Chad, because I just didn't want to leave you alone. I didn't think you could do it by yourself. So here I am.
Well, it's funny because I realized something about you today that I haven't realized in a long time. And I think the three of us can all relate. I don't know if I've ever realized this about you because I didn't know you had it in you. But so,
I'm nervous.
Sometimes with what the three of us do, and Jeff as well, sometimes we bite off a little bit more than we can chew. And it's just go, 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 go. And then, you have all of these aspirations. And so, for instance, I mean, you were on family vacation and then you did this and then you did that. And you've got all this crap going on at the office. And then you go to Minneapolis, St. Paul. And then you come back and you're so excited for COIS Symposium, which I know you still are. But then all of a sudden today, you're just kind of like, and you're like, I don't know that I really even have it in me to get on a plane. And that extra 24 hours, whether it's your family or the meal tonight or just whatever it is, just kind of recharges you. And tomorrow you'll be ready to go. But deep down inside, I know part of you, because I know you too well, is kind of like, damn, this is nice to actually just kind of be home tonight. Yeah,
100%. Yeah. I don't know how that all got through a text message, but you are 100% correct.
Because I think we've all been there. I think we've all been there. And for me, it always happens. It's never in the summer. It's always January, February. And I'm already looking at January, February, and I'm going to be like, go, 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 go. And then occasionally, it's also like that in March, April. And,
and then there's June and July.
Yeah.
And then August and September.
And then that one event that cancels like 2 weeks before, and you're deep down inside, you're like, not deep down inside, but superficially, you're like, why are you all canceling 2 weeks before? What's the cancellation policy? And deep down inside, you're like, hell yes, yes, So it's just kind of one of those things. And I realized that about you because I thought you were just always go, go, go. And today
I don't have an off button.
I was like, JB is tired. She's tired. So
especially that's an emotional roller coaster the last week, like lots and lots of highs and then stranded lows. And
you actually there's a part of me that's having PTSD about being in an airport for 16 hours. Yeah. Like I don't want to go back there again. There was too many decisions to make, too much uncertainty, too many people sleeping in the aisles. Like it was like a lot. It was a lot.
So I get it.
But I jinxed myself. Have you ever been to the Minneapolis airport?
Mhm.
Yes,
Yep.
numerous
This
times.
was my first time. And I had never seen so many cots in an airport, just kind of random. Like there's no snowstorm, there's no regular storm. It's just like there's just a lot of cots and people were sleeping everywhere. And I walked through with my business partner and best friend, and we're walking through, and I said, why is everyone sleeping everywhere? Why does this airport have so many people that are stuck? I don't understand. I've never been stuck in an airport before, jinxed myself. And she said, really? I've been stuck in the Minneapolis airport 3 times. And I said, and there's like a guy with a cot bin, and he walks around, he picks up cots and he delivers new cots. And there's another guy with a pillow and a sheet bin, and he's walking around giving people sheets and pillows and picking up dirty ones. And I was like, I mean, this is a legit business model. There's people stuck here permanently. There may be people living here. I'm not 100% sure. And she goes, it's just the Minneapolis airport. It is the Minneapolis airport.
But
So, I actually used to work at the Minneapolis airport. I don't know if you knew this.
No, you did not.
I did too. I was that guy that was full of sheet. What
were you saying, Ryan, that was probably more intelligent?
wow. Yeah, that set the bar pretty low.
Really low.
Twofold there, I bet. One is Minnesota people are just flat nice. They are
really
nice people on the whole. But also, it's like, think of all the winter storms that they have go through there and how many times people probably get stranded in like November, December, January, February, March. I think it thaws out in April or May or something.
Yeah, then they got that week of summer.
Yeah, that's it. No, my business partners are from Minnesota, and I'm from Iowa, not too far south. So, yeah, lots of winter storms, but those folks up there are just genuine nice folks.
Yeah, the guy walking around with cots, like, I just have cots.
Yeah.
You want a cot?
So back in the day, I used to go do a lot of KOL events for 3M, and 3M used to have this amazing resort. Apparently they sold it in northern Minnesota called Wanawak. So we would fly into Minneapolis, St. Paul, and we'd go to 3M headquarters for a day or two, and then they'd take us to the 3M airport, and you'd fly up to Wanawak on their corporate Gulfstreams, and then you'd stay there for a few days and have the most amazing time of your life, and then you'd fly back to St. Paul on their corporate Gulfstreams. So you've had this life of luxury for 3 years, and then a bus picks you up and takes you to Minneapolis airport, and it's like back to reality, folks. Back to reality. And I, like you, it's funny that you say that. I mean, maybe we need to send a letter to Minneapolis, St. Paul, because I have been stuck in that airport. That is the only airport that I have been sitting up against a wall, falling asleep for hours because my flight's delayed. And I think, I mean, I don't want to quote this, but I don't know that there's a hub for anything at that airport. I think it just might be that airport. Delta's a hub there? Mm-hmm. American's not. I know that for a fact. So, well, anyhow.
I'm here now. There tomorrow.
Yeah.
Walsh, how's your week going?
Good, man. Saving this world one tooth at a time over here. Reaming and
a lot
screwing.
of apices met this week. A lot of apices.
So my business partners are out this week. They're actually going to Minneapolis. They're traveling to Minneapolis tomorrow morning.
I would not go there right now.
Yeah.
It's not good.
It is their every year trip. They take off a week, and so I'm the only doc here in the office.
Did they get
in? I'm not sure. I should actually check with them later today.
Because they're probably stuck somewhere in between.
They fly out early tomorrow, but it's direct here to Minneapolis. So DFW to Minneapolis. So yeah. So but heck, life is good here in the endo world.
Good. Well,
exciting as either one of your adventures, but that's the life of
someone's got to do the actual
right
work.
Down the middle,
Yeah, someone has to do the actual work.
Yeah.
JB, do you have any news for us?
A little bit. It's the summer, so ex-presidents are getting assassinated, new presidents are not running again. Like, it's been a very busy week from a news perspective, but maybe not so much from a dental news perspective.
I believe there was a press conference right before we got on the show, a speech from the Oval Office.
There was.
Anyhow, probably shouldn't get
Can we
into
count that as a pulse check?
Yeah. Yeah, that's it.
All right.
So,
That's fair.
well, why don't you get to some news, and then we'll get to the meat of the story for tonight.
There's
All right.
the meat to the story.
I don't know. Maybe there is, maybe there isn't.
Probably not.
Yeah.
Yes, of course.
All right.
Endo.
News.
All right, let's go. So, just a few small stories that I thought would be of interest to discuss tonight. The first are for patients that are taking tamoxifen or have taken it for breast cancer treatment. And some folks, and I definitely have patients that have been on tamoxifen for a long-term treatment for cancer. They are finding that there may be a correlation with premature tooth loss. So as clinicians that are doing our health history and intake and correlating what we see clinically with helping patients understand risk assessment, if they've had a history of tamoxifen or, are currently taking it, there may be some correlation for them to worry about an increased number of teeth that won't survive for their life expectancy. This particular study came out of the Med-Oral Patol Oral Circle Buckle, which is out of Peru. I'm sure I totally slaughtered that. But they were looking at the
Circle
correlation.
buckle?
Yeah, I did.
Is that like around the buckle circumference?
It's surbuckle or
Okay,
curbuckle.
just want to make sure. Okay.
Yeah, I totally butchered that. Out of Peru, looking at correlations between premature tooth loss and the use of tamoxifen. So perhaps there'll be future correlations that we may see. I do think it's always interesting that we don't give sex hormones enough credit for the roles that they play and many of the other pathways within the human body. We think of them obviously with estrogen, progesterone, and testosterone as primary sex hormones, but they have a tremendous responsibility in the human body for many other pathways. Ask any postmenopausal woman, and they will tell you that for sure. So it would not be surprising to me if a drug that has direct responsive reaction to estrogen in a woman's body usually, but guess it could be used on men as well for breast cancer, that we might see that there would be negative sequelae that may come from that. So certainly something to continue to watch. The only other kind of interesting news, I guess, that came out of this week, Ohio lawmakers have actually been working and busy. So congratulations to Ohio. I'm not sure any other governmental agency is actually working right now. Good or bad, not sure. But Ohio was busy this week with passing two particular bills. The first bill was that they have decided to join the Hygiene and Dentist Compact. So they will be participating with many of the other states now that are on that compact for license portability. So, they've already hit the critical threshold of the number of states that needed to be a part of the compact in order to start making their own regulatory decisions and decide what this would look like from an actionable level and how they would provide license portability. But additional states continue to join and want to be a part of the conversation, Ohio being the most recent. They also passed a second law related to dental benefits this week, more specifically correlating non-covered services for dentists and allowing dentists to be able to receive compensation fairly for services provided that are non-covered services. They wanted more clear language on how dentists can bill for those services that are not covered by insurance. I think we may talk a little bit more in detail about that tonight with our controversies discussion, but that is always a hot topic for most dentists. If you're doing elective treatment, you want to do 20 veneers, you want to do complex fixed hybrid work, etc., that is not routinely covered by a patient's $1,500 annual maximum for dental benefit, and yet you're unable to accurately bill a patient for the services being rendered. I think states are trying to reconcile this particular gap in the code and also to help dentists be able to provide the appropriate care for patients when requested and as needed. So good job, Ohio. you're coming on the heels of Florida, who also passed very similar bills most recently, not the compact, but non-covered services bill as well. So with that, that's the news.
Riveting as always.
You
Oh,
rock,
Be riveting.
Do you live in Ohio?
I don't. I've always wondered what a Buckeye is, though.
It is
It's a nut.
It's a
It's
nut.
a non-edible nut. It's actually poisonous.
So
being an Iowa Hawkeye, we're in the Big Ten.
Yeah.
I'm all too familiar with Ohio State, and almost always for all the wrong reasons. They just tromp on us because they are the Ohio State. But every once in a while, we get a sliver of hope. And I was at the game when we beat them like 52-28 or something like that at Kinnick. So I have to revel in that victory from 8 years ago. But I'll take
that
it.
one victory.
good Lord, I think Iowa might have scored 52 points the entire season last year.
I don't know that that's the case.
It might not be true.
So hey, now that we know this, we can refer to them as the Ohio State Poison Nuts.
Yes.
Okay.
Yes.
You're on fire tonight, Duplantis. You are on fire, my friend.
I cannot. My in-laws all went to Ohio State. My husband is a huge fan, and it's a big stick to Ryan. So for me, they're the Ohio State University.
The Ohio State University. God bless them. God bless them. So, we had a lot of conversations recently about what we could talk about tonight. Jeff came up with a great idea. So, Jeff, we miss you, but thank you for the idea tonight on how to be profitable in today's current dental environment. We know costs are going up. There's a lot of things that are going on. Just this week alone, I've heard a ton of dentists where patients have been receiving calls. That's a nice hairy arm right there. Patients have been receiving calls from insurance companies that they're asking, telling patients that they need to look for an in-network provider. They're leading patients to believe that they're not going to pay for an out-of-network provider. There's a lot of uncertainty. There's a lot of things that are changing. There's a lot of questions about, can I do this type of restoration even though I don't get compensated for it? How do I get more compensation and whatnot? So let me just lay down the little geography here. So I'm fee for service and have been my entire career. Has it always been best for us? It's worked. It's worked for us. We've had our ups and our downs, and right now, fortunately, we're thriving in a fee for service environment. JB, you've got kind of a mixed bag, dental practice, right?
I'm
Fee for
probably
service.
85% PPO.
Okay.
And remaining is fee for service. Mm-hmm. And I came from a group practice that took everything, DHMOs, capitation. So I've seen like the absolute lowest part of the compensation structure.
And Ryan is in a specialty practice. He's an endodontist here in the Dallas-Fort Worth area and South Lake Keller, a little bit more specifically. But Ryan, what's the makeup of your practice?
We are now a fee-for-service practice. So we're, I guess, out of network with all insurances, although we will file it for you. But that's new for us as of 3 years ago, I think.
Okay.
So my partner started the practice in 2010. I came on in 2013. And at that point, we were still on 3 or 4 different dental insurances. And we kind of carried that up until the last 5 years. And we cut back one and then went another year and cut back one. And so finally kind of pulled the plug, I think 3 years ago. So, yeah.
Okay. So let's open this up with a couple of questions. JB.
Yeah.
You've been doing this a long time. Same practice model the whole time.
Yeah.
And I don't know if we should go there first or last, but let's go there first. So how has your makeup benefited you, and what do you think are the keys to profitability within your practice?
So because we did cold start practices, meaning no patients day one, being in network was probably pretty critical to the rapid success of our practice. And I don't say that from a like braggadocious perspective, but I do think going in network brings you in patients that maybe otherwise wouldn't know you exist, or whatever. And so from day one, we were in network with a fair number. We've definitely scaled that number back to the ones that we at least, I want to say, enjoy working with, but aren't the biggest pain in the butt to work with. And the compensation structure is at least reasonable. So we've definitely honed that number down to 5 or 6 that seem to continue to serve us well. I will say the business model that we built in the beginning with the PPO structure in mind to build off of is more challenging to be profitable now than it was when we opened in 2010. And a lot of that has to do with the inflationary responses that we've had in the last 5 years, between staff costs going up and just the general cost of doing business has gone up. I mean, everything that we purchase, down to utilities, consumables, obviously staff and benefits, taxes, et cetera, everything has gone up. And yet for a PPO and network practice, our fee schedule may have gone up, but you don't really see that reflection in the overall income. So I do think that original business model is getting compressed a bit. And I think it's not as easy to make that a profitable model. If you'd asked me in 2010, how do you build a model that can be very successful? It was a very specific playbook, and you could absolutely build this really unique fee-for-service PPO hybrid where you had a lot of the touch points and that customer service experience of a fee-for-service while we were still in network. I think that ability has become much more challenging for sure.
I would agree. And my next question for you is, have you dropped a lot of insurance plans over the years since you've been in practice?
Probably 3 or 4 that we dropped over time.
What do you see happens to those patients? Do a lot of them stay? Do a lot of them go? Is it 50-50 or?
Yeah, I'd say it's probably in that ballpark. Okay. I think it's weird. I think patients genuinely believe they can't go to an out-of-network doctor. I think, we feel obligated to let them know. And I don't know, Ryan, if you did that as a specialist because your relationships are a little more short-term, but we felt very obligated to say, hey, just want to give you an update. We're going to leave this particular network. You can still come here. We don't even collect in full. We'll still file your, everything about your experience will be equitable to what you were doing when you were here as an in-network patient. But at the end, you may have a copay that would be for preventative services that would have normally been 100%. But so many of them say, well, I can't come to you anymore. You don't take my insurance, almost as if it's a gateway. I don't have the membership card anymore. And I don't know how to educate or change that with patients so that they understand that they still can access benefit. They can still have coverage. Yes, maybe they'll have honest to goodness, we dropped one insurance company, and I think the increase for out-of-network patients went to $2 for their preventative visits. And so when you said to a patient, well, now we've seen a couple of you come through and we can tell you your difference is $2. They're like, is that it? I'm like, yeah, that's it. Oh, and by the way, I'm not in contract anymore. So I can negotiate with you. I can offer you discounts. I can help along the way that I don't have the ability to do when I'm under contract. So
I've got a great segue to Ryan, but before I do that, I just kind of want to go over a couple of statistics here because, and I do want to put a disclaimer out there that this podcast is not meant to disparage any insurance company. It's not meant to disparage any dental practice that assigns to insurance companies, and it's not meant to knock any of that. I mean, we're fighting the fight just as you are. But one of the things that I want to bring to light based upon, what we've been discussing so far is I've done some research on this. And in 1970-ish, the average dental reimbursement was $1,000 to $1,500 per year. And in this year, the average dental insurance reimbursement maximum is $1,000 to $1,500 per year. So that hasn't changed. But the cost of a crown back in those days was $100. The cost of a crown today the average cost is $1,460.
Yep.
So there's been a humongous increase in our cost, not necessarily just to the patient, but the cost to us. And insurance hasn't really recognized that. But the other thing that I want to say is that insurance companies, God bless them, they're out there to make money. So they're going to charge you a premium. And if you want that premium or to cover as much as medical insurance does, it's a completely different animal. And it's never going to do so unless you're paying tenfold of the premium, because they've got to make money. They've got to be able to support us. They've got to be able to spend money. Medical, loss ratio will definitely help us if that's passed throughout. But right now it's not there. So, there's a lot in dental insurance that really needs to change. But as a consumer, you need to understand that in order for that to change, your premiums are going to go up. I mean,
in that same vein, Chad, I was reading a similar statistic, and I think dental insurance was invented in the 50s. It stayed the same. And if you want to adjust for the cost of cost of living, cost of procedure increases, it would be $6,800 per person per year right now.
Yeah.
Oh, I mean, that's a huge disparity. I mean, that's what almost, I'm not a math guy, I'm an endodontist. So like 4 or 5x, really more than it is right now. And that's just not there. That will never be a feasible number.
But let's not forget the statistic. Less than 6% use full benefit every year. And less than 40% use benefits at all.
Interesting. Very interesting.
And those statistics come from the ADA. So essentially, just to break that down, that means that less than 6% of those who have dental insurance actually meet their maximum every year. And less than, we'll just say 40% for fun, 40% of patients that are insured actually use their benefits. It's a remaining 60% that are provided it for free through their employer or pay $3, $6, $8, whatever a month to have dental benefit and don't even go for preventative services.
So JB, we have a, sorry, I wanted to circle back to your point earlier that patients really don't know. Patients don't know that just because we're not contracted doesn't mean A, they can't come. And I think equally, if not more important, they will still help you use your insurance benefits. As a matter of fact, we'll file it for you. So the only difference there is that instead of having to agree to a contracted fee, our fee is a set fee, but we'll still apply your insurance benefits toward it. So if you're getting a crown, it's $1,400. Let's say you have $1,500 of insurance benefits. You're still not paying anything or, a very minimal amount for a deductible out of pocket. That's still a covered procedure. So yeah, it's this very interesting narrative that I think something that needs to be dispelled, but it's one of those things where it's propagated and then not stopped by the insurance companies because that's to their disadvantage, right?
Ryan, how much pressure do you get from other specialists, or not other specialists, from your referral base to be a network? Do you feel, and maybe more so early on in your career and, as you're sort of establishing your reputation, yes, I do good dentistry and I bring all of this to the table. How much do specialists in general, you think, are sensitive to that and feel pressure from us or other patients to join?
Yeah, I think when we were phasing out of network, that was a really hot topic when we would chat with our dentists or go to visit them. Like, hey, so you ever going to get back in network with X? I'm like, no, sorry. Like, or, hey, we really like to refer to you when you were in network with this company, but now we're just sending you these patients who are in network with this company. It's like, okay, I understand, but let the patient make a decision, right?
Mhm.
Many times, like you said, JB, it was $2. Ours isn't necessarily $2, but it's less than 10% many of the times. And so when we kind of explain it like that, it's a much more palatable expense or a much more palatable um, topic. But part of it is too that I think a general dental office who is really geared in on, you know, HMO, PPO really doesn't want to waver from that. They have a hard time sometimes having that conversation of, yes, we're referring you to a specialist who's out of network, but you can still apply those benefits.
Well, and I'm going to come in on the GP side
Mm-hmm.
and defend them for a second to
Sure.
say,
Yeah.
you know, if you're looking at a patient that needs root canals, crowns, and a bunch of other stuff, if the singular root canal eats up a higher percentage of that benefit, then you're like, okay, wait a minute. There is motivation. If the patient, I mean, I always just refer to the person who I think does a really great job and we have a really good working relationship and whatever. And I try not to look to see whether or not they're in network or not. But invariably, patients sort of sort these things out. But I can also appreciate that they're like, yeah, but that will only eat up $600 of my benefit. And now I can go get the crown, get the
Sure.
crown lengthening, the perio surgery they've also recommended. I've got to do 16 different cavities. You know, like there's all these other factors
Totally.
playing in, right?
Totally. And I hope it didn't come off like I'm
It didn't.
saying,
No.
explain. No, that's not at all the case. You're totally right. If you have a laundry list of things to get through, it kind of comes down to who do you want to pay out of pocket for? Do you want to pay out of pocket for your crown?
Exactly.
Do you want to pay out of pocket for your endo? Do you want to pay out of pocket for scaling? Because if you have an extensive treatment plan, I mean, you're going to be spending money regardless. It's
For
just
sure.
who you're paying out of pocket because those benefits are gone like this. And many specialists are not in network. You know, I guess here being in the Metroplex, probably a higher percentage are just because you're in a big urban environment. But I mean, when I was back in Iowa, 15 years ago, give or take, there were very few endodontists at all who took insurance. You know, I don't know what the atmosphere is like now, but
I can come at this from a little bit of a different angle because, you know, I get patients that I'll go to refer to a specialist and they'll be like, are they in my network? And I'll be like, you know what? I'm not in your network. Oh yeah, that's right. And you know, the thing is like, I'm like, you know, do you want the best or do you want somebody that's in your network?
Wait a minute. I take umbrage with that comment.
Yeah. And I say, well, no, I'm talking about for a specialist. I know you're the best, JB. I know you're the best.
I'm not the best, but that's not defined by my in-network status.
But you know, the thing is like I'm like, okay, I'm going to send you who I refer you to.
Who I think does a great job.
And exactly. And you know, the thing is, I hate to say this, if somebody is adamant that they want to go in network, I will say, feel free to send me your lists. And I'm happy to share with you who I've worked with or who I'm comfortable with. And the sad part is when I get those lists, I rarely know anybody. And I don't disparage anybody on the list. I just say, you know what? I cannot confidently tell you that any of these people on this list are great and going to take great care of you because I quite frankly don't have the experience. And I say, you know, your choice is as good as mine when coming to this list. However, this is who I work with. And the hard part is really when it comes to an endodontist because I have to dig so far into the drawer to find somebody that's worth a damn. But for most of the other specialties, it's really easy. You know, it comes really easy to say, this is who I work with, you know. But no, all kidding aside, I mean, you know, patients respect that. And I give them the opportunity. But if I see somebody on the list that I've worked with before that I know has done a great job, I'm happy to, but I never say, oh, these people are horrible. Never any of that. It's just, I don't have experience with these people. I'm not saying they're good or they're bad. I just don't have the experience. However, I have the experience and I know that you're going to have a great experience in these offices. And I always give them a choice.
Now, JB, with your insurances, you said you're in network with 3 or 4, maybe it's 4 or 5, something like that. Okay. So are you direct contracted with those insurances, or do you
Correct.
go through like I don't know. I don't know what the right word would be, like a clearinghouse where they're in
Uh,
network with a bunch of
yeah,
others. Like you set up your
clearinghouse
one.
and third party.
Say
No,
that again.
we're primarily direct contract.
Okay.
Yeah.
So do you have trouble negotiating those fees, or how often do you revisit that?
I have two companies that I have difficulty having any type of negotiation, but the rest are actually quite amenable. They have a time set that's every 2 or 3 years. We reopen the discussion and we go back to the drawing board to have that. And I will say, recently we were going to leave a different company, and we said, look, we're going to have to part and go our separate ways, and they came back to the drawing board and they were like, we would really like to have you reconsider and let's relook at that. So I would really encourage practitioners that don't threaten to leave unless you really mean it, because you really have to be able to stand behind that. But, if you've been a good practitioner for them and you provide good quality dentistry, and whether we like it or not, they absolutely have metrics on you. They know how many times you've billed out for the same tooth with the same filling surface. They absolutely have ratings internally for practitioners, both within insurance companies as well as these third-party companies that are starting to rate practitioners. So whether we're privy to that information, they know. And if you feel confident that you've provided good quality care to your patients, and we're not perfect, and sure, there's been misses along the way, but for the most part, you've done right by your patients and you bill reasonable procedures. Then when you give them your service notice that you're going to terminate, it does catch their eye, and they would like to keep good practitioners within their network. So you do have that feather in your cap to say, okay, well, let's have an additional conversation and take a look at the fee schedule. So practitioners do have that power to do that, but there are some companies, specifically one or two, that will not really negotiate fees. And, at that point, you just have to decide if that's a tolerable fee schedule. But there are some really good reports that you can run in your practice. And I do a couple of lecture series on that, but it's really important to know how many patients are in your practice in each network, how much profit, how much income you are generating from each, not just the number of patients, but also how much income that's bringing to your practice. And then the percentage write-off on average that you're taking from each of those particular in-network companies. And then every year we recalibrate against that to say, is this 2%, 5%, 15% of the practice? And if we leave it, we understand what that liability might mean. But, having those real numbers to actually look at to say, well, this is only 2% of our practice. Because at the end of the day, insurance companies might not like this, but you need to control who's coming through the front door, just like you do, Ryan, by leaving network, or Chad, you do by fee for service. Like as an in-network, I need to control who's coming through the door, because the last thing I want to do is have a population full of low payers of an in-network status that doesn't pay me fairly for the services that we're rendering. If I'm also in network with other companies that want to pay me fairly, and yet my book is full of patients that don't. So, you do have to look at those numbers every year to make sure that you are moving towards those in-network companies that value the services that you're providing for their patients, that you're willing to take the discount in exchange for that, and that you want to continue to fill your book with those individuals within that network.
Does your practice management software, or is there a practice management software that segments all of that out for you? Or is that more of an internal analysis that you all do?
Yeah, we do that internally, but I would say there are some great companies out there that will do that for you as well. And if you are an in-network doctor or considering, like, your fee for service, and you're trying to decide, should I go in network, or vice versa, you're in network and you're considering going full fee for service, it's really valuable to have these companies kind of walk that path with you and be a part of that decision-making process to really look at numbers. They're going to pull different reports than you're even familiar with. The other interesting thing that they understand that we don't on the ground level is how interconnected they each are. So for instance, I was in network with 2 different companies. I didn't know that if I left the network status with one, those patients would roll up under the other and I would get the higher fee schedule. But how would I know that? As the lowly practitioner doing direct contract with these companies, like I didn't know that. So you hire these companies, they know the interactions, they know the relationships. They also, as doctors, we are not allowed to discuss fees. We're not allowed to talk about what's a fair compensation structure for different procedures in your community. So I can't go to my local study club and say, I charge X for this. What do you charge? Chad, let's get together and decide that we're only going to charge X for all these procedures. It's not a legal process that we can participate in.
752.
Yeah.
Yes.
For parking.
Mm-hmm.
Yeah. I also charge $700 for parking. But
treatment's free though.
Yeah.
Treatment's free.
Yeah.
What I can do is hire a company who can access that information and help me make decisions based on that. And so I think that that's helpful. I think it empowers you as clinicians. I don't think the average provider shouldn't be running those reports or trying to make those decisions on their own without some experience. But there are definitely some key statistics to look at annually to decide, who do I stay in network with? Is this a good fit for me? And I'll be honest with you guys, I've dropped a network because I didn't like their customer service. It had nothing to do with their fee structure at all, but I couldn't get a human on the phone. I couldn't get them to answer. I couldn't get my claims paid in a timely manner. Like, it was more administrative costs on my end just to get my money back for the procedures I had already provided than it was. I don't even care about the fee structure anymore. Like, we're done with managing this particular relationship. And I think there's some intangible values that come with companies that provide good customer service, have domestic customer service. I think those are things that are really important.
So,
Jake, no, I was going to ask you guys, and I don't know if I'm allowed to say a name on here, not of an insurance company, but are you guys familiar with Dental Advocacy Group?
Oh, yeah.
So, I mean, I guess a plug here for our ADA friends. But I found out about this recently, and Chad, JB, please correct me if and where I'm wrong. But I thought the concept was really brilliant, to be honest with. So basically what they do is they do the negotiating with the insurance companies for you. So I don't think a clearinghouse is the right word, but they're a company that has a bunch of relationships with many insurance companies, big, small, medium, everywhere in between. And so if you sign up with this dental advocacy group, they already have a set fee schedule of what you can charge. But it's substantially higher, at least in the endo world. I don't want to speak as a broad brushstroke, but at least in the endo world, it was substantially higher than a lot of the other in-network fees that we had been receiving years ago. I mean, substantially higher, very close to fee for service in some cases. And then the way they structure their fees are that you get their flat out fee schedule. They'll show it to you. They'll give it to you. It is what it is. But then you pay them kind of like a subscription per month based on the number of days that you work. And it's really pretty nominal. But I thought that was a super cool approach. Yeah. And I think ADA members get a discount from it. I don't hold me to that. But again, another perk to be a part of ADA. But I thought that was a really cool structure of getting into an insurance network, but yet getting the best negotiated fee already. And then you don't have to spend your time negotiating the fees yourself.
Well,
I was just going to say, I mean, you didn't necessarily misspeak, but ADA basically negotiated a fee for the practitioners that are members of ADA.
There we go.
With dental advocacy group. So yes, it is, I'm sure, a discounted fee compared to their usual fee for ADA members. And I'm sorry, JB, I missed.
Well, no, and to piggyback on what you just said, Chad, in addition, the lobbying power of a large group, like what dental advocacy group is able to do, is the same thing that DSOs are able to do. If you're like, well, I can take a collective group of providers, 100, 200, whatever, and I want to get this particular reimbursement schedule for these providers, there is strength in numbers. And so DSOs are able to provide the value add of having all these practitioners. And if you bring them all in, here's all these in-network providers. And dental advocacy group is doing the same thing, but for private practitioners, which I think is so important to be able to take a private practitioner and say, you can be a part of a group and you can leverage that to get access, turn the key and get access to all these fee schedules that other people don't have access to. I'm so glad you brought that up, Ryan, because that's a phenomenal group. And there are others out there, but I do think they're doing a great job. And private practitioners, let's go back. Remember when I said the business model that we set up and we said that would work back in 2010 of being this hybrid PPO fee for service practice based on the current fee structures and whatever is very difficult. We didn't have a dental advocacy group. We didn't have ADA. We didn't have these collective participating groups, buying powers and other things that we could join to say, we need to find profitability within this fee structure, either increase the fee structure or decrease the expenses or both, so that we can still pay our bills and make sure our people are being paid. And now there's like a really interesting market space that's happening for those individual practitioners. I think it's awesome. I'm so happy that they have a home that they can kind of go to.
I actually had a referral tell me about dental advocacy group. So then we had to do a little research into it. And I was like, thank you so much for bringing that up. What a cool concept.
Yeah.
You know, there's a couple of things that I want to get to before we close because we're getting close to the end here. But one of the things that I want to talk about is it came up today on one of the groups that we follow on social media where, and JB, this may be more directed to you because Ryan, your procedures are pretty standard, pretty stock and trade. But for us, you know, we have a patient that comes to us, they need a crown on tooth number 15. No, I mean that in a good way. You know, I mean, you don't ask somebody what they want to fill their canal with, do you?
I'm out.
So,
he's a big Resolon guy. Didn't you know?
So
yeah, I live and die. We die by Resolon.
I want to hear what each of us would say to this, how each of us would answer this question. But this dentist has this patient that comes in, and the patient is adamant that they want a gold crown on a posterior molar. I mean, adamant that they want a gold crown. Well, in the fee schedule, based upon the insurance, the gold crown is paid at less, just in dollars and cents, than the ceramic crown. However, we all know that the cost of gold is much higher. So let's just say, for instance, that they get paid $760 for a gold crown. And that gold crown very well could cost them close to $500 in a lab bill with the cost of gold and whatnot.
Wow.
So how do you, JB, you probably deal with this on a regular basis. I have my answer canned, and I'll share that with you in a minute. But JB, I want to go to you first. How do you tell that patient whether you're going to or not going to do it?
First off, I love gold. So I absolutely want any opportunity to put a gold on a tooth. Like, I wish more patients were on board. So I would like to reduce the barriers to care for gold. But the reality is that if the lab, first off, I would say, I have been working with a lab that flat fees gold, which has made it much easier for me to be able to provide gold because I can say, yes, I know my lab bill, it's going to be X. Because you're right, Chad, before I found that particular lab, I would scan for a gold crown and I'd send it off and I wouldn't know if my lab bill would be $300 or $700. Like, you would have no idea. And so So I'm very sensitive to that. But Travis Campbell or whoever can correct me if I'm wrong. But if you document your lab bill, and if that lab bill is substantially different than what the normal ceramic cost would be, put that in the chart, and then you're able to charge the patient the difference. So let's just say your lab bill is $500 for your gold crown, but your normal lab bill for ceramic might be, I mean, gosh, they're anywhere right now from 75 to 140, probably.
Sure.
The difference is a reasonable fee exchange to the patient. So anytime I'm doing gold, I tell patients the cost is going to be the same to you, but you may have a higher out of pocket depending on what your insurance decides they want to do with that fee, because I'm going to have to pass on the cost of the gold. But when I explain the advantages of gold and why we're choosing it for that particular scenario, they're usually on board for that additional expense. But you can definitely pass on the materials cost, but you absolutely have to document your lab fees. So invoices should be scanning into charts, and there should be some type of substantial notification between what you're currently paying for ceramic and what it would cost you for gold. And then you have the opportunity to pass that along. That's the same for fixed hybrid work. You know, when you submit the lab cost for fixed hybrid work, anywhere from $4,500 to $7,500 is roughly, you know, what I've been a part of. And so documenting your lab bills is really important because that's not the cost of a denture. So if you submit the CDT code for a fixed hybrid and they downgrade it to a denture, you're still able to charge the patient additional monies correlated to that materials charge associated with that case. So it's really important to document your lab invoices to justify how you're billing patients, for sure. You can't lose money. And I don't think most insurance companies would be an advocate for you losing money.
I think that's really interesting, JB. I didn't know that if you documented and it was a substantially higher lab fee, that there is justification to charge the patient for, you know, your profit margin, or I guess.
Yes. Now, this is me learning from other gurus within insurance, so this is not advice, but I would definitely look into that. But, you know, I've been studying Charles Blair and a bunch of his folks for a long time, and that was definitely one of the things that was pretty clear is if you have justification for why you need to pass on charges to the patient, then you have the capability to do that. But if you just willy-nilly decide, I just want to charge the patient more for certain things, and you don't have it documented what it actually costs you to do the procedure, it becomes very difficult for you to make that justification if you got audited by the insurance company.
And I also think it's interesting the insurance company wants to pay you less for the gold, when in theory it's a more conservative prep, the less likelihood probably of coming to see me for an additional fee. And in theory, they should last longer. I mean, I don't want to say that, with modern ceramics are absolutely incredible, but you know, the longevity of gold crowns, I mean, is amazing. I don't know why. I'm sure they have their metrics and
well, I think you could go back to what you said before. Dental insurance has been around for 50, 60 years. The maximum allowable for the year, 1,000, 1,500, hasn't changed. And I think you see the same thing on the reimbursement side of codes. Any insurance now that's still taking, when you submit a 3-surface composite and downgrading it to an amalgam, it's the same mentality of, well, there's a cheaper material out there. And at some point in some alternative universe back in the 1980s or 1970s, gold was cheaper than doing ceramic. For sure. I remember having conversations with patients saying, well, the cost of gold and ceramic is the same because gold's material is a little more expensive, but the human effort of ceramic is higher. So the cost is about the same because we're paying in labor here and we're paying for materials here. That's not the case anymore, right?
No.
This is being manned by machine.
Yeah.
Actually, gold is now being manned by machine, but the materials cost is still high. So the whole paradigm shift has happened, and the reimbursement structures, per usual, hasn't really kept up with how materials. And in fairness to the insurance companies, it's truly fluctuating on a daily basis, right? Gold can be high today and low tomorrow. So it makes it hard to make codes and reimbursement structures based on things that they can't control.
So, well, Chad, you said you had a canned answer. I want to hear your answer too, because this is all really interesting for me to hear about. Because, yeah, my fees, like you said, are kind of just right down the middle. They are what they are. I only do like 10 codes. So,
and the thing is that my canned answer is that, and I say it's a canned answer because I was thinking of how I could respond to this person. And this is a fee-for-service dentist talking to a dentist has an insurance-driven practice. And it was like, quite frankly, if it's cost prohibitive for you to do so and you don't have any way out, then you need to tell the patient, I'm sorry, I'd love to do this for you because I do think it's a superior material. But you need to have a conversation with your insurance company because at this point in time, it's cost prohibitive for me to do so. I'm basically, if you think about it, if your margin is slim, you're paying that patient to put that restoration in their mouth. And we can't do that or we'd be broke. That's what creates bankruptcy, and fortunately we're not having to do it on a daily basis. Some people might be, but you've got to just straight up tell the patient, I'd love for you to do this, but you're going to have to find a dentist that's willing to do it because at this point in time, it's cost prohibitive for me to do so. Now, it may not be if you can add these extra lab fees, and I wouldn't even know how to code it. I've seen some of these treatment plans from other offices where they have the restoration, they have the lab fee, they have this, they have that. Cool. I know Travis has talked about that and whatnot, but if it's not going to be beneficial it's got to be beneficial for both parties. You want to do what's in the best interest of the patient, but you've also, I'm sorry, we've got to make a living in doing this too.
And I really appreciate that comment, Chad, that you put it back on the patient to say, this is a service that's best for you. Either you want it, or I think there's distal 12-year molars that I want gold on all day long. Like zirconia doesn't work. It's too rigid. Anything less than zirconia breaks. Gold is actually the preferred material, but I got to put it back on the patient to say, you need to go advocate for yourself with your insurance company to be able to get the benefit that you need at a price in which we could be able to provide the service. And I think it's super important that patients are advocates for themselves to push the insurance companies to recognize what's happening on a ground level. I don't know how many are engaged with that. I don't know how many watch this podcast right now to say what's really happening on the ground level to know.
Yeah. And for if people are watching this, and I know that this doesn't just go to dentists anymore now that we're on YouTube, but some patients may be seeing this, advocate for yourselves and, help us fight your insurance company because, maybe I should not say fight, but help us all work together and do what's for the betterment of you and for the dental industry in itself. We're out of time, folks. I think this was a wonderful conversation.
Every time we hang out with Ryan, though, we could just chit chat all night long.
We could, and I think we should. So let's just keep this going till midnight. He doesn't have to get home to his girls tonight, but
they're in bed. Game on.
There you go. Hey, but I do want to say that once again, this message tonight was not meant to disparage any practice for being, insurance driven, disparage any insurance company for what you do, because in the end, we're all trying to do the same thing, and that's make a living in doing so. And I don't ever discredit anybody for trying to make a living and do what's best for their family and their people. But one thing that I would say is that if you are an insurance driven practice, don't also feel like you're closed in, because there are people, products, services out there that can help you become more profitable in doing so. Just because they say this is what you're going to make doesn't mean that's what you have to make. You can make the best out of the situation that you're in, and there's people, products, services out there to help you in doing so. And I'm just going to give a shameless plug to one of our biggest educational partners, Ada. Ada Education has a wonderful library of resources for you to benefit your practice, educationally, profitability, mentally, so on and so forth.
Yeah.
There's a bunch of wonderful things through Ada that can help you and your practice move along and in the right direction. So with that, that's the show tonight, folks. Donk, thanks for being here, buddy.
Thanks for having me, y'all. Appreciate it.
Yeah. Well,
JB,
and JB,
glad to get to reconnect. Chad,
Same.
good to see you, buddy.
good to see you too. I'll see you, I'm sure, soon. But JB, it was so great that you made it tonight. Sorry you didn't
Thank
make
you,
it.
Delta, for
Seattle,
allowing
but-
me to be here today.
But hey, thank you for being here because it was wonderful to see you. So
Same.
y'all have a good evening.
Have a great night.
Good night,
Okay.
everybody.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.